And I have the pleasure of moderating this session with my fantastic surgical partner, Dr. Vinayak Bapat, who will also give the keynote lecture for this session, Transcatheter Mitral Therapy, what we have to look forward to. Vinny?
Thank you, Paul. Sorry, you have to listen to me again now, pre-lunch and post-lunch. That's my only conflict of interest, I think. These are my real conflicts of interest. But I think if we look at the transcatheter mitral field, we can't just look at TEER or TMVR, because I think we do more of valve-in-valve, valve-in-rings, valve-in-MAC, and many other things. And we know mitral valve is very complex, but just look at the top two lines. This has proven challenging in terms of patient selection, patient benefit, device development, and most importantly, imaging, which again is getting better with time. And all this is going to help us beyond 2023 in treating these patients. I'm not going to spend a lot of time on evidence and graphs, but just give you a landscape where it's going. And TEER is really well established, but what about other players in terms of giving us a so-called a reliable toolbox? So MitraClip, of course, was the first of them, which came nicely, and you can see that now it has progressed to a very reliable tool in treating mitral regurgitation. And we have now a second similar iteration, and there are 6 other clip-like devices developed in Asia and China mainly, which are going to enter the market at some point. So from TEER, what are my expectations and your expectations as we go ahead? Is to achieve really good MR reduction. We know now very well that grade 1 or less, and especially in light of the 2 trials which are running, surgical trials, and we also need a good follow-up. That means just doing a TEER procedure is not the end of that for the patient. And similar to TAVR, where we think of lifetime management, we need to continue this engagement and see if so-called TEER failure, which is an inappropriate term, but again, we learn from that. And it could start from pre-op considerations to post-procedural considerations. And again, the Heart Valve Collaboratory, I think, has put these guidelines. But these guidelines are, important, because say if it's in the yellow zone, I would say to Paul that maybe I think we should try the clip, and if it doesn't work, then let's see if surgery is an option or not. So what are the different options for so-called failed TEER? One, of course, is medical treatment in elderly patients who are high risk, but you could consider them for 3 other things. Surgery being one of them, but this is just a case, thanks to Sabbagh, who shared this with me. This is a patient he had done, and this patient, again, was 90-something old, came back with single leaflet detachment. So he went in again, and then used a X4 now and got a really good result. So again, good follow-up. He didn't wait for the patient to go into heart failure, and then made sure that he did a timely treatment. A really good appealing concept could be removal of the clip or displacement of the clip, and then do a TMVR. There are, of course, challenges in terms of how we manage that. If it's on single leaflet or double leaflet, can we remove the clip or not remove the clip? But these cases have been done now in practice for valve-in-ring as well as TMVR. And I think there's a lot more to come in terms of dedicated devices maybe. And again, more important thing is what do we do with multiple clips? Because most of the time patients get at least 2 clips. Surgery, again, I wouldn't go into detail here. So what is the algorithm we follow? When is surgery possible? When is TEER possible? And I call this try-TEER, but I think this is very important. You can see if the TEER anatomy is unsuitable, our balance shifts more towards surgery, but that's not the only thing. We also look at life expectancy of the patient, because if the life expectancy is on the lower side, then putting these patients through a surgery, a more invasive treatment may not be ideal, but we also look at the risk of the procedure. So again, taking these 3 things in a conversation is going to guide us into better results with TEER and other things. Annuloplasty devices have proven promising before, but now proven, of course, disappointing. But Amend is the main player now in the market. This is a ring. This is just an animation. This is a fantastic animation. Just keep an eye on that ring. It's like performing yoga inside the left atrium. I think, but this ring has been done in 10+ patients now, or maybe even more. And the whole idea of this concept is to form the ring in the left atrium, and after doing this circus, get the anterior anchors into the trigone, pull the anterior annulus behind. This is opposite of surgery where we bring the posterior annulus forward, and then put the anchors and adjust the ring and release the ring. So we are going to see more of this concept, very elegant. It has been done now in many cases. This is just to show you what's on the horizon. Leaflet augmentation, there's a renewed interest now in leaflet augmentation, and there are multiple, again, augmentations as you can see here. Some augment mainly posterior leaflet, but there could be a possibility with Naira Medical to do augmentation of both the leaflets. The concept somehow look like this. This you can call it a half valve, so to speak, or a filler like a half moon. But essentially, if implanted properly, it can give you a good coaptation line and a plane for the functioning anterior leaflet. Now, can it address both functional and degenerative MR? Is there a risk of SAM we introduce, and what is the possibility of future intervention is, of course, up for discussion. Naira Medical is completely different. Some people say this is like a SLDA. So this is like a clip which has slipped, but it has essentially got augmentation attached to that clip. And the whole idea is that that augmentation is going to help you in terms of eliminating the regurgitation. So again, this has been, this company has a lot of investment now, and we are going to see more of this hopefully in future. Cords, this at least I would say mainly 3 players, NeoCord, Pipeline, and CardioMech. There have been a challenge, you need 1 cord, multiple cords, where you put, and huge experience on the transapical cord, which was basically NeoCord. And we learned a lot from that, and partly maybe applied to this as well. Added challenges have been, the anchoring system. As you can see here, there's a lot of load on these anchors when the leaflets close, and if we don't distribute them properly, there could be anchor detachments. And the second thing is how much tensioning is needed to bring the coaptation plane down, and will this change with remodeling? So again, we are going to learn a lot about these technologies, but there are certainly challenges at both ends for this. This is something we saw first time at London Wall last year. I love the cartoon, but I don't know how this is going to work. But you can see that there are 2 anchors which they use a very beautiful concept of nitinol stabilization between the papillary muscles. And once that is done, this is a complex Spider-Man net. And then you keep tightening the net, and then apparently it will reduce the MR. So annuloplasty, leaflet plication, everything together. And as we know, a lot of these concepts may be appealing, but really hard to clinically put them in practice. TMVR, the first TMVR, as you can see, 2012, followed by us in 2013. The main shift has been percutaneous, that means transeptal. And now it's not just one, but we have got many devices with transeptal experience. And this has been an inflection point, I think, this year, that we are going to see a huge move in terms of TMVR. The good thing about TMVR is it may be less dependent on the pathology. The big problem, of course, is LVOT obstruction, anticoagulation, and of course the complexity of delivering a big device through a limited real estate. So you can see here, this is an Intrepid device. Firaz has been a pioneer in terms of developing this transeptal specifically for this device. And under his guidance and experience, the EFS study is now the Apollo trial study, and more than 50 cases have now been done very well. Similarly, the M3 system, which we know the Sapien 29 very well, has completed their enrollment. I think the results will be presented at TCT. This is a dock and a valve, like a valve in a ring. And again, the biggest advantage of this is through a system which we already know and is essentially a 20 French or less transvenous system. This is just an example from John Webb's group. You can see really good result. There are some limitations in terms of annulus sizing and risk of paravalvular leak and hemolysis associated with that. Safi, which again, generation 3 now, This is a case which Thomas Modine had done. You could see in that case, this was a case with a MAC, and again, low profile device, low Neo-LVOT obstruction risk. So I think we are going to get all these devices, but the best part is this is done transceptal. So again, we are going to see less morbidity for the patients. This is the Alta valve, which is the supraannular, more than 50 cases now, and Philip Genero was involved from early days. And then this is the case Paul did in our center. You can see the advantage is not just supraannular, but this is the only device we know of where with systole, the Neo-LVOT actually increases because the cage is compressible. So a lot to learn from newer devices. And finally, the high life concept, which is now fully percutaneous in terms of arterial access for the ring, and then the transvenous access for the valve. And again, generation 2 has open cells, so you can do a lampoon with it. So again, people are thinking of how to mitigate these issues. Moving quickly to MAC. MAC is a problem. Surgery is not prohibitive in these patients as is constantly labeled. But many times we have these patients, especially re-op patients, where transcatheter valves are going to be really good option. And again, Paul has led this field for Tendyne. You can see this is one of our cases. Heavy MAC and great result with Tendyne. This was done actually more than 2 years ago. Similarly, other devices such as Intrepid, CVI I mentioned, and this is the Alta valve for MAC, again has been done on a regular basis. So more and more options are now available more than Sapien. The two development of importance is that we should know that there are 2 trials running as well, and these trials are going to define a lot. One is a repair MR trial for intermediate risk, and primary trial for, and these are surgery versus MitraClip trials. And we are going to see how they shape in future in terms of not just lifetime management, but even for option of first treatment. We have done a lot of work, and thanks to Miho, her work in TAVR deformation, coming to mitral valve, which has become a commodity now. Everything is not hunky-dory. There is deformation, there is risk of halt, and these are the patients. We do routine CT scans in these patients to keep an eye on them. And we have found that if the INR goes below 2, a lot of these patients, or most of these patients, develop halt. So I would encourage you to go back to your practices and get these patients back for a follow-up. Echo necessarily doesn't highlight halt. And again, very important to see that we monitor these patients very well. Of course, we need a better valve modification and, of course, intermediate valve sizes, which we are never going to get. So we have to learn a lot still in this field. Coming to the valve in ring, last year, 2022 and 2023, we saw a massive jump in valve in ring in United States after the approval. Some similarities with valve in valve, but some important dissimilarities as well. Again, not to go into the details, but rings change in size, shape, as well as their properties. And we need to know which are suitable rings and which are unsuitable rings. Because basically, if you choose a good ring, you're going to have a good result. If you are going to use a less good ring or unsuitable ring, you're not going to get a good result. So it's the choice of right ring, right patient is going to give us optimal result. So we have compiled a list of course, suitable, intermediate, and unsuitable rings. These are highlighted very well in the app. So when you're doing please refer to the apps. The color codes tell you what you need to do. 2 practical tips of importance in the last year. First of all is getting coaxiality. Sometimes it's really difficult. And if you read the article from Adam and the Emery group, it's very complicated. So my colleague, Dr. Simon Redwood from London, came up with a great idea. So we now give a reverse shape to Safari, somewhat behind, and this modified curve gives you really good stability and better coaxiality. So you can see that the curve kind of simulates how you are the shape of the wire is like in TAVR. And I think this is going to definitely improve your coaxiality and the movement during the case. Balloon sizing, especially for flexible complete rings, is a really important tool. And I would encourage you to all use it, especially in borderline sizes. This will give you idea to use the right size valves. And avoid embolizations and complications associated with it. And of course, now the emergence of electrosurgery. And this has really changed the whole landscape in a good way, because we have now tools to make the LVOT better. And this now not just stops at the leaflet, but we are going to see more done on the septal side as well. So I think 2023-24, we are going to see a good evidence on development of specific tools as well as the septal myectomy with electrosurgery. So to conclude, I think multiple newer solutions on the horizon. I think TR still is and I think will remain dominant therapy for next 2 decades. Replacement with transeptal will move, and I think there will be a time there could be a randomized trial between the two. MAC, we have got many options now, not just 1 or 2. And I think for valve in ring and electrosurgery, these are the moving targets, and we need to get better at that. Thank you.
Fantastic, Vinny. So I think, any questions from the panel? Any comments?
Maybe a quick one. Yeah. Regarding mitral halt, right now we probably have the most experience with valve and ring, valve and valve with the S3, but in general, is your preliminary data suggesting we do prolonged anticoagulation of these folks? Yeah?
Absolutely. So, of course, the problem with this field is not many patients come back for CTs. We normally all don't do it. So this whole conclusion is based on 30-odd patients. But if 80% of them have halt, I think it's significant. And you see the deformation is going to play into this scenario. So absolutely, I think the more we think about it is better. Now, the good part is 60 to 70% of these patients already are in AF. They tend to be on NOVAC. But when we discharge them in the community, we tell them keep a target of 2.5, but most of them, when they come for CT, it's below 2. So now, even on surgical side, we have found that. So now we tell them the target is 3. So at least they're maintaining at 2.5. And I think it's important. Yeah.
And you're switching them from a DOAC to Coumadin?
I think Coumadin is the answer. I always feel strongly as a surgeon that the whole antiplatelet thing for even TAVR, has come from coronary stent world where there were no leaflets. The surgical world never used antiplatelet against thrombosis issue, So I think warfarin is a really good drug, and it's well tolerated by patients for 3 months at least.
Are you guys doing routine CTs on your TAVRs or valve and valves for mitrals? So you just rather not know?
Yeah, well, you can see the way we shook our heads. It's like, yeah, we should, but we're not.
Well, what are you doing for Coumadin or anticoagulation after these? Empirically?
Yeah, I don't know what you guys are doing, but I'm just changing the threshold tremendously. Obviously, the very high bleeding risk patient is difficult, but anybody else I'm strongly encouraging. But to be honest, they say, really, do I have to do this for how long? 3 months, 6 months, forever? And I've been telling people after 6 months they can drop it, try to go to a DOAC then. But I don't say that with a lot of confidence, so yeah.
Abdallah, you're nodding your head?
Yeah, no, absolutely. I think from previous studies, the highest bleeding risk are the high-risk patients. So if there's a low-risk patient who's younger, I tend to put anticoagulation for at least 3 months, especially if there's some deformation with your data. And we try to optimize the valve as much as possible during the case because of exactly that same point. Until we learn more and more about Holt, and we see all these studies of the signal of worsening valve deterioration. It's still observational, but I think the more we learn about that, that'll help with the decision.
Yeah. Lucy, Suzanne, what do you guys do in the Northeast?
Yeah, similar to what you do in Mayo, but for us, going back to your CT question, a lot of these people, the halt that you pick up in the echo lab, right, they get a 1-month echo, 6-month echo, and if you see that the gradient goes up, those are the ones that will, send a message to the team that consider a CT on these patients, but it's not for all patients that we get CTs for.
I mean, I also do similar to what everyone else has been saying, but I think one of the things that we're going to really need to know more about is as this moves to lower and lower risk patients, right? At this point, we're treating these patients who are high risk. They are, prohibitive for surgery. They're older, and so, there's a little bit of laxity to some extent. But I think when we start treating more of these 60 to 70-year-old patients, which when that will happen, I don't know, but probably will, we really are going to need to understand what the risk of HALT is and what the optimal anticoagulation strategy is for these patients. And it's probably going to be Coumadin, and they're going to need to know that up front.
There's certainly more freedom to operate when surgeons don't want to operate on them. But when there are other alternatives, we have to be very scientific and try to get it right. So,
Paul, practically the risk creep has already happened. I think we have to stop pretending we all treat 90-year-olds who are in wheelchair. I've been attending this conference in 2007, and even today for live cases, whatever, people say high-risk patient, and I keep telling, don't feel guilty. The risk creep has already happened, and I think if we realistically look at it, the bleeding risk is probably because we had 2-3 drugs rather than just with warfarin. Warfarin is pretty well tolerated drug for 70 years. People have used it. So I think we should start reinvestigating, especially these patients where we have used a lot of oversizing. And I think that is what we have learned from our practice now, that we need to get these patients back.
all right, we'll move on here. Mark, you're up here. Oh, you need this. Yes, right there, the catwalk.
Good.
Okay.
All right. Hi, everybody. I'm Mark Ricciardi. Am I doing the right thing here, Paul?
Yes.
Okay. So I had a rash of tear cases, mitral tear cases with difficult transeptal issues, particularly low transeptal height. So I went back and looked at some cases, and I found one that I had some decent follow-up, just a year follow-up. So this is the title here, Tear-Free Acute MR Got Height. These are my disclosures. So the case is an 86-year-old referred in early 2022, hence the one-year follow-up thing, for mitral interventions following an episode of endocarditis. So he had long-standing mitral valve prolapse. In late 2021, he had a penicillin-sensitive bacteremia following a dental infection. And this led to spinal abscess, prosthetic knee infection, endocarditis with mitral valve veg, and new severe MR. He's culture negative when I see him. He's functional class 3. This is his screening TEE. You can see there's a large prolapsing P2 segment and what was interpreted as being a healed vegetation on that posterior leaflet and a lot of MR. The jet origin here you can see, especially on the right-hand screen. Looks like it's directed anterior and lateral, but it starts in the 2s. Mitral valve gradient is 3. The area is okay, 5.5. The next 2 images here bring up the concept of whether this is a good tear candidate based on, LA size and shape. And this is the sort of the thing I want to talk about a little bit here. But this is what brought up the suggestion, hey, maybe this is not a perfect tear candidate. So the challenge here, tear is for new onset MR like flail. In this case, endocarditis can be technically difficult. The relatively small left atrium may hinder, obviously device delivery and leaflet grasp. And in this case, it was made worse by the fact that this patient had a very prolapsing valve with a healed vegetation. And so, but despite advances in tear, really we haven't, I don't think anyway, we can talk about this, I don't think we've found a way to really buy height when we do these edge-to-edge repairs. So here's the resolution to the challenge. The first thing, number 1, was to find any height that might be there. And this is just the straightforward going as posterior as you can and in the right spot in the fossa. And you can see, despite going fairly posterior here, we were only able to get a transeptal height of 3 centimeters. You all know that that is pretty low. So, but it did allow us, I did go ahead and do the transeptal and allowed us to steer down to the valve, but you can see on the right-hand screen there, that's a very unfavorable angle into the LV to grasp leaflet. So the next step would be to not just find height, but to make some height. And this is the classic, advanced maneuver to try to make some height, where we swing our guide as far posterior as we can and then try to bring us back by using the A knob. That's the middle frame there. And these are just representative issues, but of this patient. And then, as is often the case, when you go anterior, of course, you go lateral too. So you need to put some M knob back. And I think a lot of people who talk about the inability to ever make height is that last maneuver, in my experience anyway, is putting the M back on, dives you down, you lose all the height you gained by going posterior and anterior on the knob. So, but in this particular case, we were able to get down on the valve in a more reasonable trajectory into the LV. We were able to grasp on the left-hand screen there. You can see that we grasped the AML pretty well. It's a nice little bounce of that gripper. And then able to optimize the PML on the right-hand side. And this led to a fairly straightforward second device placements. We put an XT lateral to the XTW, as you can see, mostly on the right-hand side there. Post-deployment images, I don't think this is a world beater result here, but we got a decent result with these two clips on this difficult pathology. And if I remember right, the gradient was about 4. We started at 3, so not bad. 1-year follow-up, this patient was functional class 1, had no hospitalizations, just had mild MR seen on his transthoracic echo there, obviously on lifelong antibiotics at this point. And so the key learnings from just for the operator and the team here is 1, acute and subacute MR is often seen in cases with endocarditis and acute flail. They pose unique challenges. But we're seeing more and more of them as the reticence to do surgery may be going up a little bit. Limited transeptal height alone, in this case considerably less than 3 centimeters, does not preclude device delivery and repair when the LA shape, I think, and maybe when the fossa mitral valve relationship is favorable. And our imagers might be able to talk about how they decipher that. And then the finding and making height with advanced imaging and maneuvers can result in good durable results, as I show with this case here. Thank you.
Okay, I have about 1,000 questions related to that case.
Oh, really?
So, yeah,
Good.
I'll start with question number 1, then I'll turn it over. So there's obviously a vegetation on the back of that valve. So how did you decide where to insert the clip? I mean, did you purposely put the grippers on top of the vegetation or around the vegetation? I mean, what was your attack strategy?
Yeah, so I think that our initial thought was to not necessarily completely engage the veg, assuming that tissue there would be have the least integrity of all the areas on that posterior leaflet. I think in reality, we grasped where we could. But I think because, the reason I wanted to show this, I think getting through these cases sometimes is fine, but it's really the follow-up, because if in 3 months everything fell apart, who cares? But this one, it's doing pretty well at a year. A year is not a long time, but. So I think we probably ended up going a little bit next to the vegetation. I tried to avoid it, but I don't think, I pretty much grasped where I could.
And then any thoughts to Pascal instead of MitraClip here? Because I know people have often proposed Pascal for lower height scenarios.
Right. Right. No.
Okay. All right. Nisha, you've done a lot of Pascals. You want to comment?
Thanks, Paul. I was going to sort of just piggyback kind of on Paul's question too, just in terms of healed endocarditis and this kind of concept of acute MR in that setting. Of course, we look for blood cultures, and kind of the obvious is this patient, infected. And of course, barring that those are all negative, I guess I was curious, how did you guys truly feel that vegetation was truly healed, and sort of what was the thought process behind the friability of that tissue? Because anecdotally, this is not sort of good substrate to be working on, regardless of its Pascal or, MitraClip, and sort of just the concept of TEER for these particular cases versus stabilizing that patient and considering them for some sort of a TMVR approach.
Right. Well, yeah, I do think a TMVR approach would be the next, probably most reasonable approach for this patient. Surgery was thought, at least by our local team, to be high risk. I didn't mention that because it seemed pretty obvious, but I do think that would be a reasonable thing to look at. I think in this particular guy, I wonder if his LVOT would be able to accommodate a TEER device, and the next would be just whether you can get in there and have it stabilized.
Did you use a claret, a sentinel device on this patient?
No.
Did you get a brain MRI after the procedure?
No.
Come on, who does that?
I don't get echoes after anything. I'm not an EP guy, but I will never examine a patient, by the way.
But that we expect. You are an interventionist. But other question is, I think TMVR. Yeah, what I worry actually is the more hardware we put in, worse it can get. And in TAVR we learned that in, I think, large experience from Michigan, right? For TAVR explants, endocarditis, if there's a lot of material, it erodes into the annulus, etc. So I think this strategy is really good. How long one could wait in terms of healed endocarditis is the main question. Actually, nobody knows the answer to it, probably.
I mean, the problem is if it's culture negative, you're just never going to know until you actually take tissue out and culture it. So it's a very difficult decision making.
Yeah, I mean, we certainly relied on our infectious disease colleagues, but I think they're in a data-free zone too. But they do know exactly what you said, which is you're taking a risk here.
I thought it was really interesting how you gained height, even though you started with an air hugger. So you
I
didn't
know.
have a whole lot of maneuvers left.
Yeah.
So you couldn't use minus because that would have made your air hugger worse. Gogan, I mean, any other thoughts from your end? I mean, it was just a simple clockwise rotation of the guide, it looked like.
Yeah, I mean, I think we've talked about puncturing outside of the fossa, and that's certainly a little bit of a higher risk maneuver. That can certainly gain you a lot of height as well. But yeah, aorta hugger, not enough height, bad combination.
Yeah,
Clearly,
and
we made it work.
yeah, and your instinct would probably put a little plus with that hugger, but that's going to get you into the guy's
Exactly,
apex.
plus
I mean,
would
that's not
dive you
gonna-
into the LV.
Yeah.
You run out of room real quick.
Yeah.
Thoughts from you guys?
Yeah.
Yeah.
So, one thing I always find curious is when you have an isolated area of leaflet that's extremely thickened, like we had that posterior, that P2 that was very thickened. When you're clipping it, do you worry about asymmetric grasping? Like you're obviously going to grab way more posterior leaflet tissue than anterior leaflet tissue. Do you worry about distortion of the valve afterwards? Is there any kind of techniques that you can do to help with that?
Yeah, I thought you were going to say that you saw that on the echo. Don't say it. But yeah, I was worried about that. What I did certainly want to do is optimize the PML grasp best. Once I was on the AML, I wouldn't have done the opposite, obviously. But I think just getting as much as that tissue in there and going to what Paul was saying, whether you were grasping the actual endocarditic portion of the leaflet or not. But sure, worry, but this is one of those things where I think that I had limited ability. If this jet were not in the 2s, if it was in the 3s, I'd be showing an aborted case. I'd be showing something I couldn't do probably. So I pretty much got what I could get. But I agree with you. Can I ask a question? Is that allowed? Yeah. I'm very curious about if any of the imagers in particular, maybe CT imagers, but certainly echo guys, if you think a lot about now with cases like this where the fossa is in relation to the, say, line of coaptation, because with 3D and stuff, we had an aorta hugger, but we kind of shouldn't have. But it depends where the fossa is, where I stuck, and all that stuff. So, are you ever doing that? We didn't do it in this case, but.
Yeah,
Yeah.
I do. I mean, you can do that. You can map it with 3D before.
Yeah.
So our pre-procedural imaging, when you're assessing the septum, our standard protocol is to actually sweep the septum with X-plane to figure out the best place to do your transseptal puncture. You want to obviously make sure that you're high enough to get the guide system in and come down towards the valve, but we also try to make sure that we're coming in as parallel as possible to that coaptation plane. So you can use 3D, so you start in 3D in your bicaval view, and you can try to map it so you're coming in at an ideal angle.
Yeah, we're doing a ton of that now, but yeah.
I think NPR has made a huge difference for
That too, yep.
Yeah.
Great. I think we should move on. Thank you very much, Mark. Great case. So next case is Suzanne.
All right, I'm doing this. Okay, so I am here to present a new technique that I learned this year. Here's my disclosures. So this was a 78-year-old female. She presented for consideration of TMVR in the setting of symptomatic severe MR. Now, she had a kind of a complex mitral history. She had developed recurrent subacute bacterial endocarditis actually 5 times between 1979 and 2000. And in the setting of a severely myxomatous valve, she had ended up with resulting severe MR, and she underwent surgical MV repair in 2001, had her posterior leaflet resected, and had a 34 millimeter Carpentier physio ring placed. And she did well initially, actually had no more subacute bacterial endocarditis, but did develop progressive MR that was noted in 2018, saw some possible ruptured cords, and this was followed with serial echoes. And then over the past 6 months prior to presentation, she reported progressive dyspnea with fast paces, walking up inclines. She was an active woman, but she was noticing a decrease in her exercise tolerance when gardening or doing yoga. So our other pertinent medical history, she's got AFib, she had a PVI. In 2022, she's a pacemaker, and she actually had breast and ovarian cancer in the context of Leaf-Remini syndrome, and recently had completed chemotherapy in 2021. Luckily, her labs looked okay. So shown here is her transthoracic echocardiogram, and while you can't really see the extent of the mitral regurgitation super well here, there was flow reversal in the pulmonary vein, and you do get a sense in the non-Doppler view that there's a very long anterior mitral leaflet. And so we did a transesophageal echocardiogram, and that confirmed some eccentric severe mitral regurgitation, flow reversal in the pulmonary vein, and again, you can really see that anterior mitral leaflet just flailing. So on cardiac CT cine, here you can again have a really nice picture of both seeing that posterior leaflet prolapse as well as the anterior leaflet long, and we measured it out to being 36.8 millimeters. Now, assuming that she was going to get a 29 valve in valve based off of her 34 Carpentier Physio ring, we did a Neo-LVOT measurement that came out at 2.46, and she had an estimated length of her valve implanted being 22.5. So our clinical challenge was although the fixed Neo-LVOT area was technically acceptable, it was greater than 200, given the length of the anterior mitral valve leaflet, certainly was concerned for dynamic Neo-LVOT obstruction, some possible overhang of the anterior leaflet into the mitral valve prosthesis that could impinge at that point on how the prosthesis itself was functioning. So also, since I'm presenting this here, yes, she was high risk, considered high risk for surgery. And we did have multidisciplinary heart team discussion about where to go with this, and the decision was made to pursue tip-to-base lampoon procedure followed by implantation of a 29 millimeter S3 valve prosthesis. So after gaining access, we did the usual transeptal puncture and then an atrial cystostomy with a 14 millimeter balloon, crossed the mitral valve with a 5 French balloon wedge catheter and an Estato 300 centimeter wire. We then looped the balloon wedge catheter into the left ventricle, floated that out into the ascending aorta, and what you can see here is we were snaring that Estato wire in the ascending aorta using a snare and a 6 French multi-purpose guide. We then prepared our flying V with piggyback wire converter for insulation of the remaining wire. We were lucky to have a really amazing echocardiographer who caught some great pictures for us, so yay for the imagers. You can see here that we ended up doing our transcatheter electrocautery. We performed it to the midsection of the A2 scallop. Our electrocardiographer made sure that we stayed right there. And then we did the dextrose 5% infusion. You can actually see that going on at the wire during the electrocautery. And here's some still frames that again show the progression of tip to base here. And we did make a big effort here to ensure that we kept close proximity of our 2 catheters so that we didn't have extra wire and cause inadvertent aortic injury. So after we did the lampoon, we did do a good job lacerating that leaflet, and she had torrential MR. Now, we were prepared for this, and as part of our pre-procedural planning, had actually placed a balloon pump prior, even though that we felt that she would be relatively stable. We knew in this situation would buy us some time to get the valve in place. And, certainly glad we did see hemodynamic changes afterwards. She was on some pressor support at this point, and we're glad to have that balloon pump in place. And so we proceeded with our TMVR deployment, small curved Safari wire, although now I'm going to try using that special Safari extra curve that I just learned about here. We did a further atrial septostomy with an 18 millimeter balloon because we had difficulty getting our delivery catheter across, and then deployed a 29 millimeter S3 ultra valve. Under rapid pacing, we did put an extra 3 cc's in. She had some mild PVL that was noted, and so we did a repeat balloon valvuloplasty with an extra cc, and that improved our PVL from to trace. She, with all that ballooning of the atrial septum, she did have this very large slit-like transeptal puncture that was noted. It was 18 by 11 millimeters. She had a fair amount of left to right shunting. And just given the extent of how big it was and the fact that it wasn't particularly circular, it looked a little bit torn, we made the decision to go ahead and proceed with a occluder device, which we placed, and subsequently she had no further shunting. And here's our final result. She had a trace to mild central MR, trivial PVL that you can see. Her mean mitral valve gradient was 1. There was mild flow acceleration across the Neo-LVOT with a mean gradient that was estimated at 4. And you can really see on the right there the lacerated and kind of flailing anterior leaflets as they were split down the middle. Post-procedurally, she did really well. She weaned from her balloon pump, was extubated on post-op day 0. We transferred her out to the floor on post-op day 1, where she got her echo, which showed a well-seated valve, minimal mean gradient. She had no significant PVL and no LVOT obstruction, and she went home with home PT on post-op day 2, and when she was seen in 30-day follow-up, she's feeling well. She's re-engaged going to Zumba at the Y, and she's got significant improvement in her quality of life. So what did I learn? Well, I learned about considering both fixed and dynamic Neo-LVOT obstruction. While I always kind of think about it, it's always the fixed that seems to be right on my at the forefront of my mind, but certainly in this case with the extremely long anterior mitral leaflet, that was certainly going to be a concern here. The prophylactic balloon pump was very helpful for us, so planning for acute hemodynamic instability post-lampoon might be helpful, and then ensuring that there's close proximity of guiding catheters with no excess slack and careful imaging during laceration to ensure that we can prevent some inadvertent aortic injury during electric cautery was key. And I really do want to give a shout out to my fantastic colleague, Dr. Nilay Patel, who allowed me access to his case. I was able to come in and be part of it. He was the primary operator. I want to give him credit for that, and knows that I'm presenting here today. Thank you.
Suzanne, really great case. Because there's a ring, is the tip to base lampoon safer? And because it's going to stop at the ring. And was that the logic behind using that rather than base to the tip?
Yeah, that, and also because it seemed a little bit easier to do. But no, yes, we felt that it was going to be a little bit safer to do that. We know we'd stop at the ring. And when we did look, while we were concerned about how high up the ring had been sutured into the aortomitral curtain, it actually was relatively low, and so we felt that we had enough distance to do that.
So I just want to ask the room, how many people have done lampoon or routinely consider it? Because there is some hesitation in doing it when it's necessary. So any thoughts from the panel in terms of when you use it, and are you measuring the anterior leaflet length? I think it's critical. We saw from Brian's paper that anything more than 28 millimeter puts that dynamic risk at place.
Yeah, it's certainly critical, 20, 25 for that AML. I do think, I was going to bring up the point that you did, which is, not all rings are the same, and where they're sutured into the anatomy is very important when it does come to injury when you're doing lampoons. So that's something we think about. Did you think about edge-to-edge repair here?
It was discussed.
That's enough. No, but
it was, yes. So the
yeah.
answer is it was discussed. We did think about. We thought it would be really challenging to grasp that anterior leaflet. Obviously, it was a huge valve, and I wasn't worried about mitral stenosis in that case, and that wasn't something that was, problematic. But it was felt that we just probably wouldn't get a great result.
Suzanne, that's a really sort of fantastic case, and I think one thing that you really nicely exemplified about this particular mitral case is, unlike our TAVRs, there is a and can be acute hemodynamic instability. So really props to your team in highlighting about being prepared for that sort of acute onset of that potential for torrential MR. And we see that not just in the case that you showed, for example, with Lampoon, but even for valvuloplasty pre-tendine and MAC, or even just preparing for that TMVR procedure. So I think that sort of conversation with anesthesia beforehand and sort of setting up the team for success is kind of a very important thing, particularly if you're going to do sort of a preparation move prior to the actual mitral procedure itself. And the second question I wanted to ask was there any hypoxia that you noted as you guys were assessing the intraatrial shunt, or was it just purely from the size of the shunt?
It was purely from the size.
Yeah.
She actually remained stable from a breathing standpoint. The real concern was that, and usually, at least in my practice, I don't routinely close these iatrogenic ASDs for a lot of reasons, and especially in her, where she had already had a PVI for AFib. And I'm like, that one doesn't hold. We're going to have to go back in, and now she's got this huge device in place, and I know you can possibly get through it, but it's going to make it difficult. So I don't usually routinely, but given the size, and honestly, it was the shape, it looked very kind of torn. There was just concern that was not going to close down enough, and that we could have an issue there.
That's fair. Because as Vinny alluded to earlier, with the experience that we had with transeptal TMVR evolving, a lot of times we are able to get away without closing and keeping that option open of keeping that septum open. Congrats, that was great pace. Thanks.
The only other thing that, when the patient was a little unstable, did you consider using the Astato rail to pull your sapien in? Because some people have done that, and the reason why is because the rail is just as strong as the Safari. The only thing is you don't get that fancy curve that, in the LV, because it's going to be pointed a little bit towards the LVOT, but you do get, rapidity, and if you're counting on self-centering, you can use the Astato as a rail to pull yourself up to there.
So we didn't think about that,
Yeah.
but actually do have a second case of this coming up that's scheduled next week, and now I will.
It's just a thought, but you do have to be careful you don't cheese slice, because obviously it's a thin wire, and when you create these rails, and the bias and stuff, you want to be super careful. So you put the guide close to the anterior leaflet, so that when you create the rail, the guide serves as a kind of a cushion, so you don't cheese slice things. But it's just another thought.
Yeah,
So
the curve is better idea.
yeah, the curve is, if you have time and whatever, it's totally.
But getting across the septum, you mentioned you had difficulties. So even just to get across the septum,
Yeah, you could use that, or if you
I like that.
pre-dilate it before,
Yeah.
and then you're ready to go
Yeah.
with the sapien. Yeah. All right, great case, Suzanne. Thanks
Thank you.
so much. Yeah. So, we come up with these funny titles, and we leave it intentionally vague. So, Abdallah, Leaflet Paucity.
Thank you so much. All right, good afternoon, and I'll be presenting a case of leaflet paucity and transcatheter success. So I have no disclosures. So this is a 73-year-old gentleman presented with a history of symptomatic severe MR, has a history of mitral valve repair with a 36 carbametics annuloflex band. It was an incomplete band, 2 years prior to presentation, with concomitant CABG ascending aorta repair. And then prior to presentation had a recent ICD-related endocarditis, so they had to swap out the device and treat him for that. So this was the TEE when he was presenting with dyspnea on exertion. There was severe MR from commissure to commissure, and then you see the incomplete ring with a large anterior leaflet, which with no, you can see on the 3D on the bottom part, there was no posterior leaflet that was visualized, at least en face on this view. And then here's the 2D of the same patient. You can also see and appreciate that we had our imager kind of MPR across the valve to see if there's anything we can capture posteriorly. And there's just this either remnant or small posterior leaflet that's super tethered, or maybe it was a cord too, but it was predominantly a large anterior leaflet. So we had a multidisciplinary discussion regarding what to do with this patient. So there were 3 options. Option 1 was an edge-to-band repair, transcatheter edge-to-band. Now, it has been done, and people have shown success with it, albeit the other cases may have had just at least a little bit more posterior leaflet in that case, as opposed to this one. Option 2 was TMVR, which because of the endocarditis, the comorbidities, and the anatomy too, the patient was not a candidate for that. And then finally, redo high-risk surgery. So we had a discussion amongst us and amongst the patient, and he wanted to give it a try. The expectation was set with the patient, There's a high chance we may not succeed, but we'll give it a shot and see. It has been done before. So we took the patient to the cath lab, and we used an XTW. Of course, we use all landmarks, TEE and fluoroscopy here. And we basically used independent gripping. First, we grabbed the anterior leaflet and then swung posterior, and then sandwiched the band between the gripper and the arm. And you can see that here on fluoroscopy, as well as on the TEE, that the band was sandwiched. And then we started closing, 1 turn, 2 turn, and then it slipped off. So it slipped off the posterior end. So we repositioned. This happened twice at least until we had the discussion: should we keep going or maybe give it one more shot? So we went a little bit more medial. Again, we gave it a good try. This felt a little bit more confident because we had the band was more tucked into the gripper line posterior, into the gripper as well as the arm posteriorly. And so we closed slowly, returned, and removed any tension. Remember, there's a lot of tension here built because we grabbed anteriorly and swung a lot posteriorly to tuck under the band. And so we did that very slowly and methodically until the arms stopped moving. And we didn't continue closing again. The key here is not to build tension. And so we were very happy about it. There was some reduction in the MR. Here, good or perfect is the enemy of good. And there was a bridge, you can see that on the bottom right. And it stopped closing at 30 degrees, so we decided, okay, we waited a few minutes, it didn't dislodge. We felt good about it, so we tested the lock and then removed the lock line. And then suddenly, those are the 3 words you don't want your imager to tell you in the case. Where's the clip? So step on fluoro. So the clip had embolized, and really it remained attached to the gripper line, thankfully. So what we did was we did a transseptal puncture at the level of the clip, grabbed the distal end of it. Once we got a hold of the distal end of the clip, we manually removed the gripper line and pulled across the septum. And again, luck was not on our side, but was on our side at certain points, because the clip closed as it was being removed across the septum. But now we face the second problem with these situations, is that once we grab and snare the clip, it comes out perpendicular to the opening and the os of the sheath, the second sheath that we obtained to put the snare through. And so what I did was we removed the mitral clip device, kept the sheath, pulled it down below the clip, and then put another snare to snare just the distal end of the clip, and it was successful. And we lined it up parallel or at the same plane of the mitral clip sheath, and we were able to pull it out and obviously aborted the case. Now the patient went to the OR a couple of weeks later, had a little bit of a rough course, but survived it. At least we gave it a good shot. I'm going to also just show this, just to drive a point here. This is from a separate case, but it's a good tool to have when doing complex steer. The first video is not playing. Do you mind playing the one on the left? So this is the ONO device. It's a basket that you can put a snare through it, and when you snare a clip, it actually stands it up. And you can then pull back, and it pulls immediately into the sheath, so you don't have that perpendicular effect when snaring the clip, and it doesn't get stuck at the sheath. So just something to keep in mind that I recently figured out. So in summary, transcatheter edge-to-band repair is a challenging option in patients with failed surgical MVR. Posterior leaflet absence carries risk of clip embolization, and just always be ready for plan B. And I also wanted to bring up, for those who tried these cases, is whether or not some posterior leaflet would help in these cases versus not. But I'll open that up to discussion. Thank you all.
This is a situation of where, thanks for sharing.
It's always tough to,
It's
probably the only one sharing an aborted case, but that's
rich
good.
emotional experience,
Right.
I bet. So we've had some success with clipping the bands, as I think you know, and it can be daunting. And we're counting on the fact that the surgeon didn't cut everything out. And you're right, clipping right onto the band makes it hard. Sometimes just going really posterior at the transeptal and just pulling things posterior, you pick up things that anchor, but anchoring right onto the band, I can actually see that when you go more medial, it allows your mandible to be more posterior, and that allows you to close a clip a little bit further, but it didn't allow you to close it all the way because your clip would have to tilt posterior, which would bend the mandrel. And so to me, it kind of makes sense why you weren't able to close it completely and why you're able to get it more medial. But I certainly applaud you for trying. I mean, that's a difficult case. Mark, Suzanne, Lucy?
You said you closed the arms to 30 degrees?
I just kept closing until the arm stopped moving, and I didn't keep going because I don't want to, tension is the enemy here. There's already a lot of tension built in the system. So.
Yeah, I mean, I guess that's the only other thought is, do you keep those arms as open as possible? And whether that's enough to reduce the MR, but keep it on that band. Yeah, these are obviously very tough, and I think what Paul was saying is, can you gather just a bunch of cords or something underneath with a little bit of band, and maybe that's enough to keep things. But you had so much tension on the AML, and you had no PML, so that's.
It could have been the AML that pulled you off, all the same. Goggin, Nisha, you guys are nodding your heads? Yeah.
That's very interesting. If you see any post-surgical repair, which especially with classic resection, so there are two techniques which are used. One is resect and one is putting artificial cords. So when we put artificial cords, there's still the normal leaflet height, everything is there. Only thing is it stands down like that. And when we do resection, we reduce the leaflet height by intention. And this is done for two reasons. Is we're going to make the annulus smaller. We want to keep the coaptation plane back so that there's no SAM. So I think it's probably case done long time ago, so more resection was being done. I think in future, we all are going to see more so-called respect technique, which is multiple cords. But the interesting thing about these things is if you look at the post-op echo, the coaptation plane is below. And we need to probably think of it like that is, can we grasp the leaflet, which is much below the annular plane, and then bring the anterior leaflet, hopefully with less tension, and be able to close. But great case.
You grab more medial, maybe that there's just more leaflet over there. Instead
absolutely.
of in the middle. So, Lucy?
Yeah, you kind of have to, in these cases when you're imaging and you really have that shadow from that posterior annulus, you kind of have to start fishing around to see what you can find. And sometimes in the mid-esophageal views, your best view would be 0 because the annulus is most out of the way, or if you lateral shift your probe, maybe you get lucky. But I've been successful sometimes going transgastric, and I couldn't see anything in the mid-esophageal views. And then when I go transgastric and I search down there, I can actually see it because the shadow's different. And then MPR. So if the leaflet was completely resected, you can't do anything. But if it wasn't and it's just really tethered, sometimes doing these off-axis views like transgastric imaging or MPR, you can actually find some leaflet, and then you can try to do the clip in that view.
Now, a very important introduction of Ono basket. There have been a lot of interesting cases like excision of tumors, removal of clips. So is this basket available easily, and is it on the shelf in your lab, for example?
Yes, we had it on the shelf as a trial, but it's now commercial. I think Brown bought it, B-R-A-U-N. So they just bought it. And so I think it's good to have, especially for embolized clips, because it avoids this interaction with the sheath.
Great.
We have pulled clips fully open through the groin and then figure of 8, but honestly, it's not for the faint of heart. It's if I had an Ono basket, I would use it for sure.
Yeah. Great. Thank you very much.
Thank you.
Yeah.
Thank you.
So next case is Pradeep. You need the clicker.
Thank you. Good afternoon,
Coming
everyone.
from Atlanta, I'm wondering what this is, but let's see.
Well, you've already set the stage, so thank you for the invitation. It's lovely to be here. Let's see if we can move the slides forward. My disclosures. So I'll show very brief, 2 quick cases, because they're kind of the same theme, and love to hear your thoughts. The first one is an 81-year-old little old lady, LOL, short of breath, NYHA4, who's had recurrent heart failure hospitalization several times, comes from an assisted living facility, limited mobility, scoliosis, 57-kilogram weight, and has these comorbidities of previous PCI, TAVR, severe pulmonary hypertension, and all the routine medications. And this is what a mitral valve looks like. Severe MAC extending into the leaflets with severe mitral stenosis, not much regurgitation. We looked at the CT, and obviously you see dense near circumferential MAC with the annular area inside the MAC of around 350. Com-to-com distance is 24, AP 16, so not that large annulus, small annulus, but really no LVOT to do a SAPIEN or any other TMVR. Without the lampoon, Neo-LVOT is only 22. With lampoon, it's 167, the skirt Neo-LVOT. So the question is, where do you go from here on that anatomy? And these are some of the options. There could be dedicated TMVRs looking at the MAC patients. Obviously, Neo-LVOT becomes a challenge. You could say, well, this is too far gone. Would you operate? So those were some of the things that were going in our mind. But we thought, really, she's not a surgical candidate, and Neo-LVOT excludes everything else. So her only option will be either let her go or try SAPIEN off-label with lampoon, knowing that the LVOT is still going to be borderline even with a good lampoon. And then you look at that anterior leaflet, right, that A2, that dense calcium. How are we going to cut it, right? So that's some of the things going on. After detailed discussion, she ultimately wanted to try, and we said, okay, we'll give it a shot. Because that A2 is so heavily calcified, one of the concern is, are we going to be getting a successful lampoon? So maybe we need a little extra strategy. So we went with septal ablation and lampoon combined, same time, same setting. This is the first septal perforator. We mapped it, and on the echo, you see a nice opacification, contrast enhancement of the septum. And then after that first septal perforator, proceeded with routine antegrade lampoon. What you see on that fluoro image is the two arrows are pointing to a balloon. Normally, when you do this antegrade lampoon, you have a piggyback insulation catheter. This is balloon assisted, so this is a 5 millimeter diameter balloon that we inflated just to dilate that calcium a little bit so that that base of that V, the lampoon that you'll do it, that is wide, and you'll probably get wider lampoon. After this, we're able to cut the leaflet through the calcium, and you can, on that echo, you can see the loop is now back in the left atrium with a lot of mitral regurgitation, and then went forward with implantation of a 26 millimeter SAPIEN valve with actually a very good result. It's hard to see in that image, but the mean aortic gradient or across the LVOT AO track was around 7 millimeters mercury, and really no MR, so good result. This is the algorithm. Maybe we can spend some time on this at the end. I'll show you a very quick similar case, similar kind of gentleman, 77-year-old male, recurrent heart failure hospitalization, NYHA4, GFR of 23, and severe COPD emphysema on home oxygen, and PA pressures around 71, also on Bumex 2 milligrams BID. And this is his anatomy, severely calcified leaflets with severe MAC and mitral regurg as well. This was his anatomy. Annulus was on the larger side. Now it's the annulus is 850, com-to-com is 43, and AP is only 22. So that becomes a challenge because that's beyond our 29 SAPIEN 3 limits for the mitral side. Also, the com-to-com is way too big. He's going to have severe PVL if we try to do SAPIEN. So we evaluated him for dedicated TMVRs, but the LVOT is too small. For Tendyne was 161, plus he's otherwise sick guy, may not be a good transapical candidate. For M3, the Neo-LVOT is only 62, so obviously screen failed for that reason as well. So we went ahead and we said, let's do a septal ablation and see if we can remodify at least his LVOT, and then at least we'll have some options hopefully available. So that was a very small branch, and this is what his CT looks after the ablation. You can see that this is just virtual simulation from our own imagers, that now with that small septal branch, you have all 4-5 valve options available, at least from the LVOT standpoint. However, by this time, he's developed severe tricuspid regurgitation because the heart failure is ongoing, and that moderate to severe TR, now you have severe TR. He was otherwise a great intrepid candidate. We were going to do that, but he got rejected with severe TR. So now we're left with 850 annulus and com-to-com 43. So the question is, do you take this guy and do a Sapien 29, or do you say, well, we're going to run into problems? And this is the kind of gentleman who's borderline annoying, that he will actually call you from the hospital room. He'll call your clinic that I want to talk to the doc. I'm willing to sign on the paper that I'm willing to die on your table. This is my only chance. Do it, please. Anyways, he convinced us. So we said it's going to be bad. But here is the first valve, or at least the initial valve we deployed. I gave you away with first, but so we see multiple leaks around. And on this bottom echo on the 3D color, it almost feels like that's a central MR, but I think that's coming from that calcium. We realized that later. We realized that he has so many MRs. He has at 12 o'clock, he has that 7, 8 o'clock, 6 o'clock, multiple jets. So maybe we're missing some of the cells of those on the Sapien. Maybe we're too high on that lateral side. And then just how many plugs are we going to put in? So we said, let's do a second valve and close all the cells. At least that should reduce some leak. So after the second valve, we're left with just that one PVL on that 9 o'clock. And that we were able to plug it with a couple AVP2s. And this is the final result on the right. He was successfully discharged. So this is the last slide, and maybe I'll leave it on for discussion. If you're dealing with an open cell TMVR, look at the SCORT Neo-LVOT. And if the SCORT Neo-LVOT is over 200, then single setting Lampoon plus TMVR will work very well. If the SCORT Neo-LVOT is less than 200, then you do need some septal modification technique, whether it's ablation or sesame, whatever your site has expertise to, and then proceed with TMVR, and you may or may not need additional Lampoon. But if you're dealing with a closed cell TMVR, like most investigational TMVRs, and you're stuck with small Neo-LVOT, then leaflet modification per se may not be an option, and just think about the septal modification. I'll stop there and happy to take comments.
So, Pradeep, the second case actually, the one question, then the first case, is how many cc's oversize you did? Because that Sapien was wider than taller.
Yeah.
And I think probably 850 area, so probably needed. You had a TAVR valve anteriorly, so helpful.
Right. So that had eight extra cc's, so the syringe can only take 5, so you have to have a second syringe to have additional 3 or 4 cc's.
And the second is, how successful was the central Lampoon in the first case? Or did it get diverted to one side anyway because of calcification?
Probably did, but it's very hard to see on 3D on FOSS with that much calcium. You can almost never see the split. And that was the rationale of going with septal ablation up front, that who knows where the wire is going to deflect, medial or lateral. But piercing was actually not that hard. We found one weak spot on the leaflet LVOT view and really placed the wire right over that weak spot.
It's unlike Basilica, where if you are right in front of coronary is critical. Mm-hmm. Do you think for Lampoon you have a more, a zone where you could do it and still get away with it? I
think still you have to be in the A2 range. I mean, you probably can know this better than I do, but you have to be in that A2 range. If you're doing A3 or A1, then it may not be as effective.
Mark?
Yeah, I know these are extreme cases and stuff, but are you doing ASA on normal thickness ventricles in these extreme cases?
Yes, for TMVR, yes. And actually Mayo has published the paper also. You don't have to use that much alcohol. It's even on a, let's say, 10 to 15 millimeter septums, they just need half a cc. Because all you're targeting is not to thin out the septum. You're targeting end systolic thickening, right? So.
Yeah, the key is to inject super slow.
Yeah.
Because if you inject too hard, you can open up the collateral.
This patient was 0.4 cc's of alcohol, the second guy, and so LVOT went massive.
Yeah, typically 0.8 mLs per 10 millimeter thickness is the maximum dose.
Yeah.
So the coils coils in a hypertrophied septum don't work because of the quick collaterals that can develop in that septum. In a thin septum, maybe. I'm not sure, but that's collaterals collaterals are the reason why coils and covered stents don't work in general for ACH.
I think in thin
Go
septum septal ablation, pacemaker rate's very high.
Yeah, it
That's
is.
the
It's
issue.
very high.
But if somebody
VSD
has
rate is high.
Yeah, especially in thin septums. Yeah.
Gogan, you.
I was going to make a quick comment. I don't know if Jamie's here, but Jamie's now presented a series of about 5 or 6 patients where they had CCs that were like 40, 43, similar to yours, and he uses an anchor tier device. So he'll put in an NT or an NTW in either the lateral or medial commissure, reduce your CC dimensions. That way, when you do finally put in a 29, you're not taking it 8 CCs plus. So,
Jamie's done that. I personally don't believe it because I just cannot believe that MitraClip will hold a massive balloon inflation.
Yeah.
Paul, I don't know what.
I think again, I think it's a series is overall small.
Yeah.
But he also doesn't. You have to kind of let the device mature,
Sure.
endothelialize, stabilize, and again, it's an N of like 5 worldwide experience.
I think acutely it's just hard to comprehend the thin leaflets.
Technically, can you just describe the balloon-assisted lampoon? What
Yes.
type of balloon you use?
So this was an over-the-wire balloon and 5 millimeter diameter, and you can choose any 3 to 5, 6.
Non-compliant, compliant?
Non-compliant.
Non-compliant.
Because compliance usually, if the leaflet is that calcified, will not do anything. And we started with compliant only because it was not available. Non-compliant was not available in a 5.0 over the wire. So this was a peripheral 5.0 by 15
Perfect.
or 20 balloon.
Perfect. Other question?
Yeah, sure.
Great case. So I'm just a little bit perplexed. Why was there such difference in the PVL after the second valve placement? Because the height of the valve or the depth of the valve looked pretty good on the first implant. So the skirt should have covered it. So why did you have leak through the cells, do you think, after the first valve?
Don't know the right answer, but I think our take was that on the inferior side of the fluoro, which is the medial, so medial we landed just right. We were not sure whether we are covering all around 360. And just because there were so many different jets, we thought this may have a better chance of closing some of those.
So one of them is through the valve. The second thing is if you implant the same size valve, you will expand the dimension of the first one.
Yeah.
So in fact, in the really early days of Sapien first generation, we were able to implant a 26 inside a 23 and to get it stretched. So essentially it's just and second is it prevents recoil because now you've got 2 and that's what probably happened.
What did you inflate your second TAVR in terms of volume? Did you do 8 cc's as
Same
well?
8 cc's.
8
And the
cc's?
way to do it is you bring your valve in and you put in, because the syringe will take only 5 extra cc's, so you inject 3 extra in the balloon first. So you already have injected 3 extra, and then you just hit it all the way. We actually prepped him that you're going to get 2 valves. You'll get PVL, couple on medial and couple on lateral side.
He got 3 Sapiens, didn't he?
2
One aortic, 2 mitrals.
Aortic, yeah.
Cost of a Ferrari, I think. But I think one of the things in these patients not to forget is when the oversize or undersizing is so much is they are always at a risk of embolization or slow movement up. We have seen movements of Sapien up in a MAC even after 1.5 years. So I think these are the patients you follow up very closely and it's already very high risk patient and you can mitigate further issues.
Yeah. And not all 850 annulus are going to be the same. This guy, we took it because the AP dimension was 22. So we knew that he's going to anchor it. It will be an issue of PVL. But if it was 36 all around, that's probably not a good case.
So more oval rather than circular
Right.
is
Having a
correct.
TAVR in the aortic position, extensive posterior, AP 22, so it should anchor.
And you guys modeled it as the LVOT as if it's a closed cell valve. Because after Lampoon, if you had to do another valve, it would be
Yes.
not possible.
Yes, so his LVOT after ablation was in 300, 400 range.
Great. Thank you so much, Pradeep. So we'll move on. Our last but not least case in this session, Sachin, who decided that it was not hot enough in Houston, so he decided to come to Austin.
Thank you, Paul. Thank you for the invitation. So along the same theme for a valve and ring TMVR challenging case. Let's see. Oops, that's the end. I'm done. You guys are off the hook. Can we go back to the first slide, please? I'm sorry. This is backwards. Okay. So the case is 82-year-old lady with progressive exertional dyspnea, NYCHEC class 3, recurrent heart failure hospitalizations. Her pertinent cardiovascular history is she's had a mitral valve repair about 12 years ago and has a 29 millimeter ring. She's also undergone a MACE procedure concomitantly at the time. She's had ablations for atrial fibrillation and is on anticoagulation. She also has a permanent pacemaker and has pulmonary hypertension. So she has significant mitral stenosis, baseline gradient of 8 at a heart rate of 80 with a PA systolic pressure of about 80. And on stress echo, the mean gradient goes up to 17 at a heart rate of 100 with a PA pressure of almost 110 millimeters of mercury. And she's extremely symptomatic from this. So here are some of the TEE images in this lady. Again, a small ring, not much regurgitation, predominantly a stenotic lesion. And this is a resting gradient of 10 on this TEE. We do a CT, and even though the ring was 29 millimeter, it was a little bit surprising that the area was only about 359. The anterior leaflet length was about 22.7, so along the lines of previous cases and discussions, risk of LVOT obstruction. We modeled for both 26 and 23, and with the 26, the Neo-LVOT was about 150. With the Lampoon simulation, Neo-LVOT was much larger. And then this is the 23 millimeter simulation. Again, with the 23, the Neo-LVOT was small at about 180. And with the Lampoon, it was much larger. Tip to base Lampoon, just like Suzanne presented, was something that we were considering for this patient. As you all know, in this is a variation of the classic antegrade or retrograde Lampoon, which does not require traversal of the leaflet. This basically tip of the leaflet to the base, and it is protected by the ring. This can be considered for previous mitral valve or mitral ring, as in our case. So again, the options for this case would be redo surgery with the replacement, valve and ring with a 23 sapien with 3 extra cc's, or a 26 sapien, in addition to a tip-to-base Lampoon to reduce the risk of LVOT obstruction. We had discussions about 23 versus 26. This was a pretty small area, and with a 26, we thought that it would probably be significantly deformed, and we opted to go with a 23 with 3 extra cc's. So again, this is a transeptal approach, transfemoral, bilateral groin axis. After going transeptal, we pass a wedge catheter into the ascending aorta, and then snare the Astarter wire from the contralateral groin, create a AV rail, and then a flying V as demonstrated in the left 2 images on fluoro, and very elegant demonstration of the 3D TEE by none other than Steve Little, who is in the audience here. This is critical to position the flying V in the sort of the middle of the anterior leaflet to try and obtain an adequate and equal splay of the anterior leaflet. This is followed by the laceration, and again visualized nicely on the 3D TE image in the center portion of the anterior leaflet, or the A2 region of the anterior leaflet. And some images demonstrating the valve pre and post Lampoon. Clearly much worse mitral regurgitation after the Lampoon as expected. Surprisingly, patient remained hemodynamically very stable and did not require a balloon pump, although we were ready in case she decompensated. This was followed by the typical septostomy with a 14 by 40 balloon, and then 23 sapien with 3 extra cc's deployed in a slow fashion without any issues here. This is the fluoro of the valve in 2 orthogonal projections, nice expansion, and 3D with and without color, demonstrating good flow and no PVL really. Post mitral gradient was about 6 millimeters of mercury intraprocedurally, and here are the simultaneous LV, LA tracings demonstrating really no significant gradient across this valve. And this is the final left ventriculogram, again showing normal left ventricular ejection fraction and maybe trivial posterior leak. Next day, patient's transthoracic echocardiogram looked pretty good. No significant regurgitation. Again, mean gradient of 6 millimeters of mercury. She did pretty well. Just like the Minneapolis group, we also do routine CTs on these patients. And as you can see, the Neo-LVOT is wide open. The valve is well positioned. There's no evidence of halt. This patient is already on anticoagulation with warfarin for her persistent atrial fibrillation, and we plan to continue this indefinitely. And that is the case. Thank you very much.
So Sachin, you highlighted something really important is the ring size and the discrepancy. And so this is the ring which is a flexible ring. So when we surgeons suture it, the in vitro sizing and in vivo sizing is very different. And it's, I think I tell people it's very similar to stented versus stentless valves. And I think you did really great CT analysis and then decided the sizing strategy, etc. for this. Now, the question is why you chose 23 over 26. And with 26, the other advantage, which is less highlighted actually, is you have more height. So the placement is more forgiving. So if you are less experienced and you're worried, especially in mitral valve in ring, it's borderline sizing. It's not a crime to choose a bigger valve because you just get that 3 millimeters extra for positioning, and that may become very critical, especially in very narrow landing zone. But great CT analysis.
No, that's a great point. We did think about this at length, and our main concern was, given the very small size, we would probably end up with maybe a deformed valve. And based on Miho's work, mostly in the aortic space, we were concerned that there may be increased risk for halt and valve degeneration. Although this is a data-free zone. But good point, Vinny.
But you showed that even this valve appeared smaller. So again, congratulations. Any thoughts from the panel regarding Lampoon as well as the choice of the valve?
Yeah, I had a question maybe for people who do a lot of this. We talked about having a balloon pump up front, having one on standby. If you're using Sentinel, you're using up a lot of access points here and increasing some of your risk of bleeding. Does anybody have the sense for whether patients with MS tolerate the new MR better or worse than the person who starts with the severe MR and then gets a little worse? Any thoughts about this?
That's a great question, Paul. See what you think. But I've always thought that patients with severe MR would presumably tolerate the worsening MR better than if they had no or very little MR to begin with.
I completely agree. I think when they have MR to begin with, you do the Lampoon, they don't blink an eye usually. But the MS, the ones I've seen go on ECMO and balloon pump were the ones where severe MS was the predominant lesion. You convert them to acute MR and they get into trouble really quickly.
But this patient, for whatever reason, just didn't.
Yeah, she didn't.
Yeah.
We were ready for it. We had it in the room. In some other cases, I've used it, but we don't routinely put the balloon pump unless we think that they're really going to decompensate it or they're tenuous.
That's a great point because we do basilica. We don't see such a drastic, maybe because it's a diastolic flow, while this is a stonking systolic flow, and it just makes sense that from physiology, MS plus MR is always worse than MR getting worse slightly for 5 minutes. But how many people, when they do this, have ECMO ready? Or because balloon pump and ECMO, you need perfusionist and the whole team. So do you have perfusionist and surgical standby?
So we do this obviously in the hybrid OR. All of our TAVRs are in fact in the hybrid OR. So we are ready to get on ECMO in a matter of minutes. So this is we do it the same way.
Great. Any other questions?
Great case. We looked at our experience of putting valve in rings, and we're hesitant to put it 23 right now. I've had to go back and claw some of those out just because even if your gradient is 6, if you've ever held it as the 23 sapien ring, it's 90. It's 90, and I've had to pull most of them out of the late stenosis.
No, that's a great point. We were concerned about this. This is, again, this is the smallest, obviously, sapien that we've done. Most of the mitrals are 26 or 29, most of them. But this lady was, very frail, really not in any shape or form, suitable for surgery.
Marvin?
Well, if you look at the All right. Sorry. So if you look at the TVT data wasn't present or published in JAMA, I think in like 2020, you can see that the 23 cohort had like higher mortality and higher gradients at 1 year. And that's the only data that shows like a difference in mortality. It's retrospective data, but you know, that's the best data we have. Yeah, it's just that perpetuates this controversy of, you know, when you have like a borderline valve or a valve-in-valve, like say you have like, I don't know, like, you know, you have a choice between fracturing and putting a 26 valve in versus a 23, you know, which do you choose? You know, based on the wisdom data, I would always use the 26 and, you know, plan on fracturing with the understanding that, you know, sometimes it doesn't expand as much as you think it's going to. But, you know, that's why, you know, you try to choose your prosthesis carefully.
I'm almost suspicious of data that says there's no difference between a big valve, medium valve, and a small valve in outcome. Does that mean no one ever gets mitral stenosis?
No, I think, again, what do we define mitral stenosis? Because the majority of the mean gradients after valve-in-valve and valve-in-ring is 7. And that's moderate MS by itself, but that's the mean gradient throughout, even if you put a 29. Actually, Amar Abbas presented at TBT that lower gradients at patients after valve-in-valve and valve-in-ring had actually the worst outcomes because they actually had lower cardiac output. So part of the gradients we see is related to the cardiac output and flow. And when we adjusted for all of that, there was no difference. The mean when the gradients are 10, but the patient is not feeling it because it's something else that's causing the gradient.
Yeah, I don't buy that as a math guy.
So Amar Abbas is a good spin doctor is the conclusion. But I think the important point is, again, what Marvin, you said is critical. Say 25 true ID is a borderline between 1 millimeter oversize, you use 26, have a very nicely expanded small valve, or use a 4 millimeter oversize and use an under expanded big valve. Now, you know, this is a controversy and we're going to learn with time, but keeping them on anticoagulation, especially if you have a deformed valve, or try and optimize the shape is at least the least we can do. Same with Safi wire, which you showed, right? The whole advantage of using these things is we have to start reacting to what we see and see whether we can optimize before we go in. So one suggestion could be, you know, using a non-compliant balloon to start with to make it a bit circular. So your expansion is better and more circular. We're going to learn a lot. But I agree that a slight self-criticism, 23 S3 Steve is not different than a 25 mitral valve. And we do put 25 mitral valves surgical in these patients.
Maybe we do, but I know.
Well, I think, well, it depends on patient's annulus in mitral. So I think 25 size mitral valve is manufactured because it's used, and in Asia, it's the commonest size used is 25 and 27. So again, hemodynamics, 82-year-old, you know, quite acceptable. Thank you. Yep,
Thank you.
There's one more question behind you.
So Vinny, how much stretch would you expect from a mitral valve in ring like this? Because it's a flexible ring. I mean, valve in valve, we know they're rigid structures. You can have pinwheeling under expansion, but from a stretch standpoint for valve in ring.
Oh, these rings can expand. Yeah.
Exactly. So
yeah.
if you can put
they expand
26
because
in
they're
this.
crumpled.
Yeah.
And in fact, in the app, we have shown 3 cases where it's the same size band or flexible ring, but the configuration is different in each patient. So usually speaking, you should oversize a bit more than you would normally for semi-rigid rings or rigid rings.
So for example, in this case, could you put a 26 and stretch it?
I think you could have. You would get a recoil and probably will end up with same shape, is my feeling. Yeah.
Thank you.
Thanks, everyone. That'll finish this session and I want to thank everyone. 30 minutes and then we'll be back. Thanks.